Hello, thank you for taking the time to listen to this presentation about gastroesophageal cancer research being performed in the Department of Radiation Oncology at Ohio State. I am Eric Miller, one of the GI radiation oncologists in our department. We have 4 radiation oncologists who specialize in gastrointestinal cancer at the James: Dr. Angie Arnett, Dr. Daisy Diaz-Pardo, Dr. Terrence Williams, and myself. Gastroesophageal cancer remains a difficult disease to treat. Most patients present with advanced disease with either disease that has already spread or is locally advanced. Treatment is also very demanding, sometimes involving chemotherapy, radiation therapy, and surgery. Since the treatment is challenging, many patients become ill and require hospitalization during treatment. For those who endure all of this therapy, the outcomes are still not optimal, with overall survival at 5 years remaining around 50%. The role of radiation therapy in gastroesophageal cancer has evolved over the years. For patients with esophagus and gastroesophageal junction cancers, most patients are treated with chemotherapy and radiation therapy combined prior to surgery. For gastric cancer, when radiation is delivered, it is typically delivered with chemotherapy following surgery. There are challenges to delivering this therapy after surgery. These challenges include delays in recovery from surgery, especially if there are complications, challenges in defining the treatment areas due to post-surgical changes. Typically, larger radiation fields are used, resulting in more radiation dose being delivered to surrounding normal organs, which can result in poor tolerance of therapy. Before we get into the research, I wanted to provide a quick overview of what radiation therapy entails. Patients first undergo a planning CT scan that is used to develop a 3D computer model used to make the treatment plan. Patients are positioned on their back on the treatment couch. Images are first acquired to align the patient, and treatment is then delivered as shown here. Patients remain still while the radiation is delivered and cannot taste, smell, or hear or feel the radiation as it is being delivered. Following treatment, patients are helped down from the treatment table and return home. Treatments in general take about 15 to 20 minutes and are generally delivered while patients are out of the hospital. This is just a demonstration of what radiation therapy is typically like. So for the remainder of the talk, I wanted to spend some time discussing the various research focuses in our department. They include 3 main focus areas. The first is the development of more effective imaging technologies with digital PET to accurately stage disease and assess treatment response. Second is the development of more effective therapies, including the addition of a novel radiosensitizer, adavosertib, to radiation therapy for esophagus, gastroesophageal junction cancer, as well as total neoadjuvant therapy for gastric cancer. There's also a focus on mitigation of acute and long-term toxicity with a focus on cardiotoxicity. So I first want to discuss the imaging research performed at OSU led by Dr. Michael Knopp, Dr. Chadwick Wright, and Dr. Catherine Binzel at the Wright Center of Innovation in Biomedical Imaging. The use of imaging technology to accurately stage patients with esophageal, gastroesophageal junction cancer is very important given the morbidity and mortality associated with curative therapy. However, our current imaging approaches are not always sufficient to detect occult metastatic disease. An example of this is shown in this image where a metastatic lesion was not identified on a standard of care PET, here shown in the right hip, but was much more visible on the digital PET image. What we do not want is for such a patient to go to surgery and undergo a very involved procedure with a lengthy hospital stay, only to develop metastatic disease several months later. So there's a great need to advance our imaging technologies to prevent such a situation from occurring. We really need imaging technologies that are sensitive enough to detect occult metastatic disease, and digital PET is really a promising new tool to accomplish this goal. Another imaging tool which Dr. Knopp's group has developed is dynamic perfusion PET, which includes acquiring PET data at the time of injection. This can provide additional insight into the perfusion and biological characteristics of a tumor. Here, an esophageal tumor, shown by the orange arrow, and the activity in the blood pool, which is the aorta, shown by the red arrow, are compared from the time of injection. So we see as the activity washes out of the blood pool, the tumor is perfused and exhibits uptake much greater than the surrounding healthy tissue, shown in this graph. We are studying how this data can be used to assess or predict treatment response to treatments like chemotherapy and radiation. The next area of research I wanted to focus on was the development of more effective therapies. First, I wanted to discuss the addition of the radiosensitizer adavosertib to radiation therapy for esophagus and gastroesophageal junction cancer. We truly have an interdisciplinary team at Ohio State working on this study, including Dr. Williams of Radiation Oncology, Dr. Jalil of Gastroenterology, Dr. Hayes of Medical Oncology, and Dr. Way of Biostatistics. Esophageal cancer cells have a high level of mutations in a specific gene called TP53. We can exploit this high level of TP53 mutations with certain drugs which make the cells more sensitive to radiation therapy. This is a complicated diagram of cell cycle checkpoints, but the concept is actually pretty simple. When cells are going through the process of division, they have certain checkpoints in place to prevent them from moving forward with damaged DNA. Esophageal cancer cells with TP53 mutations already have one of these checkpoints compromised. So this checkpoint is compromised, and they're heavily dependent on the G2 to M checkpoint shown here. The study drug AZD1775 or adavosertib blocks the proteins whose job it is to keep the cells from proceeding through the cell cycle with DNA damage. So when you combine radiation and adavosertib, the idea is that any DNA damage to the tumor cells from the radiation will not be able to be repaired prior to the cell proceeding through the cell cycle. This effectively increases the chances of the tumor cell dying. So the analogy I think of is a race car leaving the pits too early, and this is what happens. Essentially, the wheels fall off and the tumor cell is prone to cell death. Data from Dr. Williams' lab has shown in mouse experiments that combining radiation therapy with the study drug AZD1775 results in a dramatic decrease in size of the tumors compared to the radiation alone or the study drug alone. And that's shown in this graph here. This is one cell type, OE33 cells, and then flow 1 cells. You can see the combined arm of radiation plus the study drug, a dramatic decrease in size of the tumors, and it remains that size throughout the duration of the experiment. There was also a higher proportion of cells with mitotic catastrophe in the AZD1775 plus radiation therapy group, shown here, mitotic catastrophe, meaning that more cells died. So for patients with inoperable or metastatic esophageal cancer, radiation therapy, it's a very effective treatment for helping to relieve swallowing symptoms caused by an obstructive tumor. However, the responses are typically not durable, and recurrence can cause multiple issues, including problems swallowing and also bleeding, which can be life-threatening. So in the era where chemotherapy is improving and with the promising results of immunotherapy, durable control of the primary tumor is becoming more important, with some studies even showing that aggressive control of the primary tumor is associated with better patient survival in this population. So with the promising preclinical results of adavosertib, the study that we are conducting is a phase 1 trial adding adavosertib with radiation therapy for metastatic or inoperable and ineligible for definitive chemotherapy and radiation patients with esophageal and gastroesophageal junction cancer. So for the phase 1 portion, the patients receive 3 weeks of radiation therapy delivered daily and a study drug during weeks 1 and 3. Following the phase 1 trial, an additional 12 patients will be enrolled who receive a study drug alone for the first week with research biopsies to verify that the drug is treating its target, followed by the 3 weeks of the study drug combined with radiation therapy. The primary objective is to identify the maximally tolerated dose of AZD1775 or adavosertib to be used in combination with radiation therapy in this patient population. So some of our secondary objectives include looking at the effectiveness of the adavosertib in combination with radiation for improvements in swallowing difficulty following treatment, time to second intervention or time to second treatment for difficulty swallowing for those symptoms, and then overall survival. And then finally, we're looking at identifying biomarkers that help predict who would respond to this type of experimental therapy. So these are the patients that we're looking to include on the study. So patients who have biopsy-confirmed esophageal cancer or gastroesophageal junction cancer. The patients must be not eligible for curative surgery and not eligible for definitive chemotherapy and radiation after a multidisciplinary review or have pathologically confirmed or imaging consistent with metastatic disease. Patients must be 18 years or older. They must be functional, so have an ECOG performance status between 0 and 1, meaning that they're a high functioning patient. Good organ function. Patients must be non-pregnant and not nursing, able to sign informed consent, able to swallow whole capsules. So the swallowing must not be at the point where they can't swallow any pills. And then patients with a prior concurrent malignancy are okay as long as they don't interfere with assessing the effectiveness of the study drug. So here are the exclusion criteria for the study. Patients who have had chemotherapy or radiation therapy within 4 weeks prior to entering the study. Patients who have not recovered from toxicity due to a different anti-cancer therapy, except for hair loss. Prior thoracic or abdominal radiation therapy for cancer. We're not allowing pregnant women, as I mentioned, patients with certain heart issues due to interactions with the study drug, and then the active use of any medications which may interact with the study drug, dabocertib. So this is the dose escalation schedule for the study drug. We start at level 1, where patients receive this study drug on days 1, 3, and 5 of the 1st and 3rd weeks, with radiation therapy given once a day, 5 days a week for 3 weeks, and the highest dose, they're getting the study drug days 1 through 5, level 3, weeks 1 and 3, with the radiation therapy again, once a day for 5 days a week for 3 weeks total. So this trial is currently under development. It was approved by the NCI and will likely be open in the fall of 2000. So I wanted to move on to another study being performed at OSU by one of our radiation oncologist researchers and faculty, Dr. Diaz, investigating total neoadjuvant therapy for gastric cancer. So again, this is a truly interdisciplinary team. Here are the investigators on the study: Dr. Ning Jin of medical oncology, Dr. Diaz, who's leading the study, Dr. Jordan Cloyd of surgical oncology, and then Dr. Michael Knopp and Dr. Chadwick Wright of radiology participating in the imaging part of the study. So for gastric cancer, we're still really working on the optimal treatment approach. Past studies have shown that postoperative chemotherapy and radiation has been found to improve overall survival compared to surgery alone. In addition, multiple studies have shown improved outcomes with the use of chemotherapy prior to surgery. In addition, the use of digital PET to adapt treatment volumes has the potential to decrease toxicity, and the resident microbiome in the gastrointestinal tract has a role in the response across several cancer treatments. Its role in gastric cancer will be tested in this study. So the primary objective of the study is to evaluate the feasibility of delivering tailored targeted chemotherapy followed by chemoradiation prior to surgery in patients with gastroesophageal junction and gastric cancer. Secondary objectives include identifying the resident microbiota and bacterial species associated with higher response to the combination therapy, and to evaluate the role of PET perfusion imaging using digital PET in the treatment of gastric cancer while the patients are undergoing treatment. So this is the trial schema. So patients get a baseline PET scan, then go on to chemotherapy first. They get a post-treatment repeat PET. They then go on to chemotherapy and radiation concurrently, so given at the same time. The PET will be used to define the boost volume. Patients then receive a post-radiation therapy PET to assess treatment response, and then move on to surgery with stool samples obtained at several time points to evaluate the microbiome. Inclusion criteria for this study include patients with histologically proven T2N0, T4A, N3M0, gastric or gastroesophageal junction adenocarcinoma. Patients are evaluated with endoscopic ultrasound, which is a scope exam, and staging laparoscopy, which is a minor surgery prior to enrollment, strongly recommended. Patients should be 18 years of age or older, good functional status, and then have adequate blood, kidney, and liver function. So please consider enrollment in this trial if you were recently diagnosed with locally advanced gastric cancer. Finally, I want to discuss some of our efforts focused on mitigation of acute and long-term toxicity of treatment that focus on cardiotoxicity. So this is a research area done and performed in conjunction with Dr. Daniel Addison of cardio-oncology, Dr. Terrence Williams of radiation oncology, and myself. So with modern treatment, the median survival of patients with localized esophagus and gastroesophageal junction cancer has nearly doubled. So while delayed treatment side effects were previously not really an issue to worry about because patients passed away early, advances in therapy have really resulted in some long-term survivors who must live with potential delayed morbidity from treatment. So patients are living long enough now because of advances in therapy. We're starting to see some of the late effects of treatment become an issue. So excess radiation to the heart is associated with increased cardiac morbidity and mortality. And for patients who survive long-term, it can be a source of long-term morbidity and mortality for patients who receive thoracic radiation therapy. So above is an example of radiation plans highlighting how more advanced planning can spare the heart. The plan on the left is using 3D conformal radiation, and you can see these colors represent the dose spill of the radiation therapy. You see the dose spill into the heart, into a significant portion of the heart, the left ventricle, left atrium, even extending onto the right. While the plan on the right uses more advanced planning where the heart is spared to a greater degree. So this is with using older technology, 3D conformal, and this is using VMAT planning where we're able to spare the heart to a greater degree. In addition, most esophageal cancers are located in the lower esophagus. This is the location of the gastroesophageal junction. And this is really the area right behind the heart. So this patient population may be especially vulnerable to the cardiac effects of radiation therapy. So above is an image of a patient's radiation plan merged with the patient's PET scan. So this is the pre-treatment images. The esophagus cancer is shown here by the blue arrow. This is the heart. You can see the location of it next to the heart. At 1 month, you can see this portion of the heart become a little bit brighter. So it's taking up some of the tracer that's used for the PET scan, indicated by the red arrow. Again, this is the esophageal cancer. When we put the overlay of the radiation dose with this PET scan, you can see, so this is the radiation dose that was delivered. You can see this area of uptake in the heart. So this area received a significant radiation dose, and the fact that there is some, this area is a little bit brighter on the PET. This may indicate an area of cardiac damage. So to evaluate this further, we performed a retrospective review of 208 consecutive patients with localized esophageal or gastroesophageal junction cancer treated definitively at OSU between 2007 and 17. And the main goal of the study was to identify patient and treatment factors associated with major adverse cardiovascular events, or MACE. So in our results, we found that 40% of the patients experienced the MACE event. So this was really high and much higher than we were expecting. Patients with pre-existing cardiovascular disease were found to have a much higher risk for severe cardiac events, but the more advanced radiation therapy planning may help to protect against these events. It really showed that we need further research into the mechanisms and preventative strategies against cardiovascular disease for this patient population. Some of the other areas that we were working on for detection, prevention, and mitigation of cardiac toxicity and treatment of gastroesophageal junction cancer and gastric and esophageal cancer include the development of innovative strategies for detection. So focused on advanced imaging technologies, including cardiac MRI, PET, exploring the use of blood biomarkers, so a blood test to also be able to identify ways of assessing cardiotoxicity. Also looking at the development of preventive strategies. So looking at both pharmacologic therapy, so drug therapy, as well as ways that we can achieve this through more advanced radiation therapy planning and delivery. So having proton beam therapy, where we're able to spare the heart over the next couple of years will greatly allow better cardiac sparing as well. Also the development of novel therapies for mitigation, so anti-inflammatory therapies, antifibrotic therapies are areas of interest that we're exploring as well. These are all areas and future strategies for ways to assess toxicity in the gastroesophageal junction and gastric and esophagus cancer population. So to summarize and in conclusion, the treatment of gastroesophageal cancer is complex and difficult with less than optimal outcomes currently. So OSU Radiation Oncology really focused on 3 main research areas. So through imaging, advanced imaging technologies, be able to better stage disease and assess treatment response. also develop more effective therapies. So we talked about the trial of the addition of the radiosensitizer adavosertib, AZD1775, radiation therapy for these patients, as well as the use of total neoadjuvant therapy for gastric cancer. And finally, looking at long-term toxicity, so the mitigation of acute and long-term toxicity of treatment with a real focus on cardiotoxicity, just because of the proximity of the radiation therapy to the heart, which can become an issue down the road, especially as therapies advance and patients live longer and longer. We have to make sure that we focus on survivorship and focus on ways that we can help lessen the burden of treatment of cancer. So on behalf of our department shown here, I want to thank you again for taking the time to listen to this presentation. I'm going to acknowledge all the team members included in this presentation. At the Wright Center, Dr. Knopp, Dr. Wright, Dr. Binzel, Radiation Oncology, Dr. Williams, and Dr. Diaz, my colleagues, as well as in Cardio-Oncology, Dr. Daniel Addison. Please feel free to reach out to me with any questions if I can help in any way. Thank you.